Hello, this is Dr. Rajiv Agarwal, Professor of Medicine at Indiana University School of Medicine and Staff Physician at the VA Medical Center in Indianapolis. I'm going to present to you the key results of the AMBER trial. The AMBER trial was first presented at the late-breaking clinical trial session of the National Kidney Foundation meeting in Boston in 2019. There was a lot of interest at that time, but the trial results were not published. This has now been published in the journal Lancet, and you can access the key results of the trial Lancet. Follow my presentation by questions and answers, questions that have been asked during the late-breaking clinical trial by the reviewers, and subsequently. I'm going to present these results on behalf of my co-authors, Patrick Rossignol, Alan Romero, Dalia Garza, Martha Mayo, Suzette Warren, Gia Ma, Billy White, and Brian Williams. My disclosures are as follows. The key ones are that of Relipsa and AstraZeneca. AstraZeneca has now acquired ZS Pharma. ZS Pharma and Relipsa both make drugs that bind potassium in the gut. Relipsa, a Vifor company, is a sponsor of the trial. Bayer is a company that is manufacturing a drug, finerenone, that is in clinical trials. It can potentially raise potassium, and that is why I have listed in this disclosure. Resistant hypertension is defined as a blood pressure that is measured accurately, and it is above a certain threshold, 130/80 according to the US guidelines, 140/90 according to the European guidelines, despite taking 3 drugs or more in adequate doses, one of which is a diuretic. However, if somebody is on 4 drugs or more, regardless of the blood pressure level, he is said to have resistant hypertension. Resistant hypertension is not diagnosed using a cursory blood pressure. We have to measure blood pressure accurately. In this trial, we measured blood pressure using a standard guideline technique, and that is using this blood pressure monitor shown in this picture, the Omron HEM 907 monitor. It can be programmed so the blood pressure monitor does not inflate till the patient is sitting for 5 minutes, and then 3 readings are taken 1 minute apart, and they are averaged to get a blood pressure that is said to be a clinic blood pressure. We will call this an AOBP, Automated Office Blood Pressure. Sometimes we have to exclude resistant hypertension using ambulatory blood pressure monitoring. Now, ambulatory blood pressure monitoring is not a trivial technique. Given the size of the trial, we decided that we will not use ambulatory blood pressure monitoring, but we did use home blood pressure monitoring in all the patients. It turns out that if we use ambulatory blood pressure monitoring, we can define the prevalence of resistant hypertension more accurately. In a meta-analysis, we found 10.8% of the patients have resistant hypertension diagnosed using ambulatory blood pressure monitoring. However, that's not the complete story. The patients who have chronic kidney disease have a 22% prevalence. Furthermore, to exclude pseudo-resistance, we have to measure drug levels of blood pressure medications. What if the patient is supposed to be taking 6 medications but takes none? Now, that's not resistant hypertension. So we have to measure the drug levels. In our trial, we measured spironolactone levels at multiple visits in each patient. We did not measure every drug level, but we did measure spironolactone levels. Now, spironolactone is a magic word for resistant hypertension because the guidelines recommend spironolactone in patients with resistant hypertension, and it's denied to a lot of patients because to get spironolactone, the GFR has to be greater than 45. These are problems that may not be addressable in patients with chronic kidney disease. However, I'll tell you how spironolactone became a key word in patients with resistant hypertension. It was really the seminal Pathway 2 study, which hypothesized that spironolactone will be more effective at lowering blood pressure than alternative treatment targeting different mechanisms, for example, a beta blocker or an alpha blocker. They took patients who had a GFR greater than 45, and they excluded patients who had a plasma potassium that was elevated during a 4-week screening period. The hypothesis that they were testing was that if you take 3 drugs, including a diuretic, then one of the drugs would be more effective. The 4 drugs they tried were either placebo, an alpha blocker, a beta blocker, or spironolactone. And it was a multi-way crossover trial. So these administrations could happen in random order. However, each drug was given in a low dose followed by a high dose. For example, spironolactone 25 titrated up to 50 milligrams. And the titrations happened 6 weeks after starting the drug. They had patients who averaged about 61 years of age, excluded octogenarians. Clinic blood pressure was elevated, 157/90. Mean potassium, plasma potassium, was only 4.1, and the GFR was 91. 14% had diabetes. So this is relatively a low-risk population for developing hyperkalemia. Blood pressure results are shown in this slide. The home blood pressure 148/85. After a placebo, it falls some about 4 millimeters over 2 millimeters. But when we give a beta blocker or an alpha blocker, the effect is much more than the placebo. But spironolactone is magical. It reduces blood pressure even more than the alpha blocker or a beta blocker. And this is what got spironolactone into our lexicon of using it for treatment of resistant hypertension. The risk factors for hyperkalemia are the presence of chronic kidney disease, a higher baseline potassium, diabetes, ASO abuse, and the dose of spironolactone. In Pathway 2 study, they excluded patients who had a GFR less than 45. The potassium level was 4.1, not terribly high. 14% had diabetes. Yes, everybody was on ASO-ARB, and yes, everybody received spironolactone when they were supposed to in a random order. In the AMBER trial, we only included patients with chronic kidney disease. We excluded people who had a potassium of less than 4.3. Our mean potassium was around 4.7. 50% of our patients had diabetes. ASO-ARB use was mandated in all the patients, and the spironolactone was necessary to get into AMBER, as I will demonstrate to you. So there are key differences between the Pathway 2 and the AMBER trial. We carried the baton from Pathway 2 to AMBER. Pathway 2 established that spironolactone is effective in resistant hypertension, but the study excluded patients with advanced CKD. The AMBER trial studied patients with resistant hypertension and advanced CKD. We did not test the hypothesis whether spironolactone will be more effective than a placebo or a beta blocker or an alpha blocker. We took the results of Pathway 2 as is, that spironolactone is effective. However, we wanted to ask a different question. Is that in patients with advanced CKD with resistant hypertension, does Patiromer, which is a potassium binding drug, enable the persistent use of spironolactone through the prevention of hyperkalemia? We had a complicated study design. They had a 4-week run-in. On average, each visit was separated about a week apart. It could be anywhere between 4 to 10 days. During this time, we measured blood pressure, made sure that they met the inclusion-exclusion criteria. We measured potassium levels and GFR. Subsequently, the patients came in every week for the first 4 weeks, and every 2 weeks subsequently for the remaining 12 weeks. Following the 12-week study, they stopped spironolactone or Patiromer and came back 2 weeks later. We studied patients who had a GFR between 25 to 45, AOBP between 135 to 160, and serum potassium between 4.3 to 5.1. Stratification was by diabetes status and local potassium level. Randomization was to Patiromer or blinded placebo. On day 1, everybody got spironolactone, 25 milligrams once a day, and 8.4 grams per day of Patiromer or matching placebo. Subsequently, at 3 weeks, we had to titrate up the dose of spironolactone to 50 milligrams if the blood pressure was not controlled to less than 120 at home. The additional antihypertensive medications could be added as needed. And we measured drug levels of spironolactone at week 1, week 4, week 3, and week 12. We also measured UACR, urine albumin to creatinine ratio, at these time periods. So we included adults with 3 medications, including a diuretic. ASO-ARB was required by all patients. They had to have uncontrolled hypertension as diagnosed by AOBP, eGFR between 25 to 45, and potassium level between 4.3 to 5.1. We excluded people who had a recent stroke, MI, or heart failure hospitalization, severe GI disorder. The primary endpoint was to look at the proportion of patients who remained on spironolactone at week 12. That is our primary endpoint. A secondary endpoint was to look at the between group difference in change from baseline to week 12 in systolic blood pressure by AOBP. We had 63 centers in 10 countries, truly a worldwide trial, and we screened 574 patients. More than half of them were randomized, about equally to the 2 groups, and more than 95% of the patients completed the study. So the study was well done, even though it was a multi-center trial. The average age was 69 in placebo, 68 in Patiromer. About half of them are men, diabetes in about a half, heart failure in about a half, About a quarter had stage 4 CKD. Albuminuria was very little. Office systolic blood pressure, AOBP, was about 145 in the placebo group, 143 in the Patiromer group. The distribution of potassium was fairly even. As you know, we stratified randomization and stratification worked. Half the people had a potassium of more than 4.7, half the people less than 4.7, and the distribution is fairly even. 3.6 to 3.7 medications in these patients. All patients had RAS inhibitors except one in the placebo group who was intolerant to RAS. Diuretics in nearly all the patients. Some of them may have been missed because they were on combination therapy. For example, if somebody on benazepril hydrochlorothiazide, we might miss it because that's not recorded in that, but I believe that everybody was on the diuretic. CCB in about 3/4, beta blockers in 3/4 of placebo, and 60% of Patiromer group. The primary results of the trial are shown here. 98 out of 148 patients remained on spironolactone at the end of 12 weeks, 66%, compared to 126 out of 147 in Patiromer group, 86%. The mean difference between the group is 20%. That's the proportion of people who are enabled to take spironolactone over 12 weeks because they were taking Patiromer. It's P of less than 0.0001. That means that this is very improbable that we would achieve these results by chance alone. Time to discontinuation of spironolactone is shown in this slide. Placebo group, about a third of the people are coming off the spironolactone, whereas only 14% are coming off spironolactone. And most of the discontinuations happened after 6 weeks. Now, potassium of 5.5 or more is a knee-jerk response. A lot of physicians would stop spironolactone, so we measured how many people were getting potassium of more than 5.5 at any time point, and nearly 70% are getting a potassium of 5.5 or more during the placebo phase. In the Patiromer treated patients, only about a third of the patients are getting potassium of 5.5. Therefore, half as many are getting potassium of 5.5 or more if they are getting Patiromer compared to placebo. The cumulative dose of spironolactone, 2581 milligrams in the placebo group, 2942 milligrams in the Patiromer group, about 400 milligrams more, about 16 pills of 25 milligrams of spironolactone more if they were receiving Patiromer. Blood pressure is shown in this slide. Very large drop in blood pressure, 10.8 with spironolactone. To put it in context, this is the same magnitude of blood pressure reduction that somebody might see in a denervation trial therapy. So these are patients with resistant hypertension who undergo denervation, and previous trials have reported similar magnitude of changes. Here we can achieve with a pill, spironolactone. With Patiromer group, about a 12 millimeter reduction, and the between group change is not significant. So most of the effect that we are achieving in this trial appears to be because of spironolactone. The time course of blood pressure reduction is shown here. Within 4 to 6 weeks, the patients reach a nadir of blood pressure. At 12 weeks, we stop the drug and the blood pressure goes up, but not quite towards baseline. The adverse events are fairly well balanced. The most important one is potassium being increased in the placebo group compared to Patiromer group. About 14% of the patients had GI side effects in each group, placebo or Patiromer. So in summary, in patients with advanced CKD with resistant hypertension, Patiromer enables more persistent use of spironolactone. 5 patients treated over 12 weeks with Patiromer allows 1 more patient to continue spironolactone. The NNT is 5, a very low number considering the trial was only 12 weeks long. The Patiromer use reduces the cumulative chance for hyperkalemia over 12 weeks to 1 in 3 compared to 2 in 3 in placebo. So NNT is even lower at 3 in this situation. Patiromer allows more persistent use of spironolactone, 385 milligrams more over 12 weeks. In other words, about 16 pills of 25 milligrams of spironolactone over 12 weeks, not a trivial number. Spironolactone use associates with about 11 to 12 millimeter reduction in systolic blood pressure. The change in systolic blood pressure between groups was similar, and the safety profile is consistent with what we have seen in previous trials. Now, I'm going to follow this with a question-answer session, questions that have been asked at the late-breaking clinical trial session by the viewers. by other colleagues, and some of them are as follows. We get asked this question, what was the mean dose of Patiromer? Well, we provided Patiromer in sachets, 4.2 grams in one sachet. The mean dose was about 12.5 grams, so which is about 3 sachets. The median dose is 9.8 grams. The interquartile range of 8.4 to 16 grams tells you that very few people in the study, about a quarter, required more than 4 sachets a day. A quarter of the people were controlled just by the initial dose, which was 2 sachets a day. So not a lot of Patiromer was needed during the trial. What about the blood pressure changes during the trial? Well, we didn't alter ACE or ARB use in anybody during the trial conduct, but additions to antihypertensive drugs before week 12 occurred only in 4 patients, all in placebo group. So not a whole lot of blood pressure changes were seen here. Were patients taking the drug when they were supposed to for spironolactone? And yes, we measured spironolactone levels at frequent intervals with using a mass spec. And this mass spec measured 2 metabolites of spironolactone, candridone, and 7-alpha-methyl spironolactone. 7-alpha-thiomethyl spironolactone and candridone are both active metabolites with extremely prolonged half-lives. And it turns out that if we measured these levels at 1 week, 4 weeks, 8 weeks, and 12 weeks, and when the patients were supposed to be taking the drug, more than 90% of them were taking spironolactone at each one of these time points. Very good adherence to spironolactone. Another question we get asked repeatedly is, why did the study fail to see between-group blood pressure changes? Well, clearly we were disappointed. We expected to see between-group blood pressure changes. We didn't. But we learned something, and we'll share our learning with you. Most discontinuations occurred 6 weeks prior to the end of the study. And this is the trial which shows the Kaplan-Meier curve that shows you the discontinuation. And you can see most of the discontinuations are happening 6 weeks before the trial ended. Why is it important? Because we found that spironolactone metabolites could persist for a very long time in this study. Recall that we measured spironolactone metabolites at 1 week, 4 weeks, 8 weeks, and 12 weeks. And it turns out that 1 week after discontinuation of spironolactone, 87% had metabolites. 2 weeks later, 3/4 had, and more than a third of the patients still had metabolites present if they were 3 weeks or more. Now, the numbers are small, but this tells us that the spironolactone metabolites can be extremely prolonged in these patients. 2 weeks after stopping the drug in all patients, more than half the systolic blood pressure lowering effect in spironolactone remained. Now, this is not something that we expected. Spironolactone is like a freight train. It's very hard to stop the blood pressure effect, because when you stop the drug, it takes a long time for the blood pressure to come back up. This is what we mean, that we have the blood pressure lowering, and you can see a nice lowering between 11 to 12 millimeters mercury from baseline to the end of the study. When we stop the drug, there's an increment, but this increment is more than half of the drug effect is remaining 2 weeks after stopping spironolactone. And therefore, if we had to do the trial again, we would design a longer study to observe between-group blood pressure differences. Well, we get asked this question. Sprint showed greater decline in eGFR with aggressive blood pressure control. Why should we bother lowering blood pressure further in CKD? Now, this is a very dangerous place to go because Sprint was designed to look at the interaction effect of CKD and non-CKD on cardiovascular outcomes. It was not a trial that was specifically designed to ask the question whether CKD patients benefit. It was asking, is there an effect modification of CKD on the outcome? And the answer was clear no, as Dr. Chung and colleagues point out in Jason article. Second, the investigators led by Dr. Malhotra measured some markers of kidney injury through KIM-1 or NGAL in patients who had a GFR less than 60. And what they discovered is that it was really the hemodynamic changes rather than the injury to the kidney tubules that's leading to the decrement in GFR, which again suggests that you're not damaging the kidney. It's a hemodynamic effect. You're protecting the heart. Use the drug to lower blood pressure. And by the way, we did not target blood pressure to 2 different levels in the AMBER trial, so our results are not like SPRINT. We have to still manage blood pressure in patients with chronic kidney disease. Patients stop spironolactone. Can you tell us exactly how many patients stop the drug due to hyperkalemia? Yes, it's presented in a table in the Lancet article. You'll find that 34 out of 50 patients who stopped the drug was because of potassium in the placebo group, 10 out of 21 in the Patiromer group. Other reasons, they had symptomatic hypertension or eGFR changes and a host of other reasons. They were fairly more common in patients who had placebo than Patiromer. So in closing, I'd like to thank the participants without which the study will not be possible, the study coordinators who really do the hard work of recruiting, randomizing, and implementing the protocol, the investigators at various sites, the Data Safety Monitoring Board, most important, the National Kidney Foundation, which gave us a wonderful platform, late-breaking clinical trial, vast audience, great questions, and we enjoyed presenting for the first time the results of the AMBER trial at the NKF late-breaking clinical trial session. And finally, the sponsors, Relipsa, which is now a Vifor company, for sponsoring the trial. Thank you very much for your attention, and you can find the full results of this trial at Lancet.